Hello and welcome to today's webinar. We still have a few people joining, so we'll begin here shortly. But in the meantime, please take a look at this interesting case while we wait. Okay, I think we are ready to go. My name is Erin Burnham, and I'll be your host for today's webinar. Before I hand over to Erin Porter, who will be presenting today's topic, I'd like to go over a few housekeeping items with you. The webinar will be recorded, and we will share this with you via email shortly. Whilst we love hearing from you, you have all been placed on mute for the duration of the webinar. We do, however, welcome your questions and comments, so please type those into the chat box and we'll do our best to get through as many as possible at the end. And finally, if you're having any technical issues, please just let us know via the chat box and I'll do my best to help. Thank you again for joining us for today's webinar. This is the first in our Equine Winter Webinar series. Today's topic is an overview of equine cervical spinal radiographic interpretation. After the webinar, we will share more information about the rest of the webinars to come. As I mentioned, Erin Porter will be delivering today's presentation. She's been with us at VetCT for about a year now. Prior to this, she was faculty at the University of Florida College of Veterinary Medicine for 10 years. During this time, she spent 5 years as Chief of Diagnostic Imaging and helped to develop and run the diagnostic imaging services at the World Equestrian Center in Florida. Okay, I will now hand over to Erin to start today's presentation.
Thank you, Erin. Okay, just real quick, in case anyone's dying for the answers for the case while you wait. This filly had a really interesting lesion, and it's a little bit of a zebra. It's something I'm not going to have time to cover today during our talk, so I wanted to just point out one of these cases. So you can see there, this horse has a occipital-atlantoaxial malformation. So if you look closely, this is the C1 vertebral body, and it's sort of confluent with the basioccipital bone. So it's sort of pushed cranially and shoved into the back of the skull and fused with it. The articulation between C1 and C2 is widened, and there's a step deformity there. So we really don't have, good articulation. It's subluxed. And if we look really closely on this image, you can see there's no dens, or it's really blunted and rounded. The caudal image of the spine was relatively normal. So all the excitement was in this first image, but I did have a couple of obliques that I wanted to share. And so on this oblique projection, you can see better the articulation between the cranial aspect of C2 and C1. It's flattened, it's malarticulating, and the dens is sort of blunted or absent. Same thing, opposite oblique, the cranial aspect of C2 at the level of the dens. There's maybe a little nub in there, but not much. And again, we can see C1 fused with the back of the skull. So not a very common lesion, but an interesting one, and one worth recognizing if you ever come across it. And so with that, I'll go ahead and get started on equine cervical spinal radiography. Thank you so much for taking time out of your day to listen to me talk. So just a quick overview of what I'm going to cover. So we're going to start with indications for cervical spinal radiographs. I'll do an anatomy review, and then I'd really like to cover some radiography tips. Part of my goal from this talk is to help you guys be really comfortable with obtaining good quality cervical spinal radiographs and as well as interpreting them. We'll cover common pathology of the cervical spine, and then go into radiographic measurements of the vertebral canal. And then I'll talk briefly about primarily radiographic myelography, but also cover a little bit of CT myelography. So clinical indications. So why do we make radiographs of the cervical spine? So some of the more common indications are going to be symptoms like neck pain, decreased range of motion, so trouble bending or resistance to things like, neck stretches, or we call them carrot stretches, where you try to encourage the horse to bend their neck, and that seems painful. Ataxia, proprioceptive deficits, lameness, muscle atrophy, the always challenging subtle performance issues, and then certainly trauma. And it's just really important to keep in mind that anytime you have radiographic abnormalities in the neck, it's super, super imperative that these are interpreted in light of whatever clinical and physical exam and neuro exam findings you have, because they alone could be incidental or don't always, mean an end all be all. So moving on to an anatomy review. So on the top right, we have a cross-sectional CT. So here's, the vertebral canal, and I'm just going to cover the anatomy and show it on our lateral cervical radiograph at the same time. So hopefully that helps build a little bit of a 3D perspective. So the vertebral canal is highlighted in blue, and that's where the spinal cord lives. It's housed between the vertebral bodies, which are shown in green, and the articular process joints, which are, bilateral true joints on either side of the spinal cord. So there's a joint capsule and joint fluid, just like any other joint, and this is where the motion of the neck comes from. And then we have the intervertebral foramen or foramina. There's actually two of them, so one here and one here, and we can see them as sort of little gas opacities right underneath the articular process joints. And I'm going to refer to the articular process joints as APJs throughout the talk, just because it's kind of a mouthful. But that's where the spinal nerves exit the vertebral canal. And then finally, the transverse processes, and these just help us identify where we are when we're making radiographs of the spine. They can have kind of a unique appearance at different sites, and I'm going to cover that and show you how they can be helpful for identifying anatomy. So just a kind of a closer look at the soft tissues in the vertebral canal. So within the vertebral canal, which is this opening, we have the spinal cord, as we all know, and then the nerve roots travel from the spinal cord out through those intervertebral foramina, which you can see here and here, but also on our sort of sagittal plane coming out here, right underneath the articular process joints. And they sit on top of the vertebral body or intervertebral discs. It's important to remember that the brachial plexus is made up of cranial nerves C6 to T2. So any pathology affecting those nerves can cause pathology in the brachial plexus, resulting in forelimb lameness, proprioceptive deficits, etc. So the normal equine cervical spine has 7 vertebrae. Several of these have unique anatomical features that I am going to cover briefly, just to make sure everyone's kind of on the same page with basic anatomy. So C1 is this guy here. And so C1 is a really unique vertebra compared to the others. It cranially articulates with the occipital condyles at the back of the skull, and caudally articulates with the dens of C2. So it should be pointed like this, very different from the case you guys looked at the beginning. It does not have true articular processes like the rest of the vertebra, and it doesn't really have a body. It's just a fat little squat guy. Something interesting about this vertebra is it develops in 2 halves, which eventually fuse. And so if you're looking at radiographs of the neck in a fold, you may see a lucent line down the middle of this, and it's important not to mistake that for a fracture. So that's where their physis lives, right down the middle. Moving on to C2. So C2 is also a unique appearance. So we have the dens, and also it has this large dorsal arch, and it has a transverse foramen or 2 transverse foramina, which in adult horses may or may not be closed. So in this case, it's closed and it makes a nice little oval, but sometimes this is notched. This part is open and it's a notch, and that's absolutely normal as well. Beware again in foals, because C2 is made up of several different separate centers of ossification, so it could easily be mistaken for fractures. Okay, C3 through 5 are kind of the generic 3 in the spine. So they all look really similar to each other. So this So it's helpful if you have basically if you have 3 vertebrae in a row that look like you're at 3 through 5, but also it can be helpful to include the back of C2 or the front of C6 to give yourself an anatomical landmark so that you're confident as to where you are in case there's variation in the spine. So in this case, I have that dorsal arch of C2 that I can't miss, C3, 4, 5, and then notice that they have open physes. So this one's starting to close. This one is still quite open. So the vertebral bodies have 2 physes. The cranial one closes around 2 years of age, and the caudal one closes around 4 or 5 years of age. C6 also has a unique appearance. I'm from Florida, so I wouldn't know, but they say it looks like a sled or a sleigh. It has these large ventral transverse processes. So it's a transverse process cranial and then a ventral nerve ossification. It's not uncommon for you to see a sort of separate little fragment here, and that's absolutely normal in C6. We're going to talk more about variations shortly, but it's important to know that C6 commonly has anatomic variations. So you cannot rely on this sled-like appearance because every now and then it doesn't have either of the ventral lamina, and it has other variations that can really make it look a lot like C5. So it's important to be aware of that. Okay, C7 is my favorite personally. It looks like a bullet, I think. So it has no ventral processes. It doesn't have prominent transverse processes. It's just a little perfect little oval vertebral body. So in this case, we have it next to C6. We can see the big transverse processes and little bullet-shaped C7. You can notice that we have increased soft tissue opacity here, superimposed on that C7 vertebra. And that's because this guy is nestled right under the soft tissues of the shoulder, which makes it a lot more challenging to get to radiographically. So we'll cover some sort of tips and tricks on how to get your radiographic image of C7 to look like these. I recognize this can be a real challenge in the field with portable units. But one of the biggest things I can say, and I'll probably say it again, is if you increase your mass and collimate heavily, like I would say this is actually too much, not enough, too much of an open collimation. I like it almost like little postage stamp size. You'll really reduce scatter and increase your image quality drastically at the level of C7. So just a little tip to try there. And then finally, T1. Now this area is even further under the shoulder, so we can actually start to see the scapula here coming in. But here's our body of T1, and we have ribs coming off and a true dorsal spinous process on this. And that reminds me, I should say here, C7 also sometimes has a little baby dorsal spinous process. So just because you see that doesn't mean it's T1. That can be present and it may not be present on C7. So back to T1, we have ribs, dorsal spinous process. This is under a lot of tissue. So this image is really challenging, maybe not even possible in a lot of horses to get with a portable X-ray machine. For this image, we use somewhere around 100 kVp and 150 to 250 mass. So it really does take a lot of X-ray penetration. Okay, so going into common variants, there's been several papers on this in the last few years. And so it's kind of a hot topic. And what we know is that there are lots and lots of different variations that can occur in the equine neck and cranial thoracic spine. So the most common of these is, like I said, transposition of the ventral lamina of C6 onto C7. So that's an example of this here. So this is C6, and notice it doesn't look sleigh-like or sled-like. It just has the cranial transverse processes, but we're missing that wide, flat ventral lamina. And if you're looking for it, and it's subtle, you'll see that little transverse process or ventral lamina on C7 where it's supposed to be a bullet. So it's challenging to see. You kind of have to look for it, but it's quite common when you do look for it. Then there's lots of other variations described involving the ribs. They can have block vertebra, lack of a vertebral body, etc. But this is the most common. So what's the clinical relevance? Why am I even talking about this? So it's most important when you're counting, you know, if you're going to inject a neck or you're identifying a region with pathology, you want to be really confident where that is in the spine. And so we need to be able to look at this and recognize, okay, this is C6 and 7, not C5 and 6, even though it looks like it. So being able to still count appropriately can be challenging in the face of these variations. Our vertebral sagittal diameter ratios, which we're going to go over shortly, are based on normal necks. So it's possible that those ratios and measurements will be affected by abnormal variants. Certainly you don't want to mistake it for pathology. So sometimes you could see this and think, oh, there's osseous proliferation or there's something wrong with that C7 vertebra. So it's important to recognize, what variants happen. And then finally, could it be associated with clinical signs? So we know from recent literature that this particular variation, the transposition of C6 transverse processes onto C7, is not associated with clinical signs, at least in warm blood horses. But certainly there's room to speculate that some of these other vertebral anomalies may cause instability in the neck or abnormal soft tissue attachment sites and could potentially be clinically relevant. Okay, so just going over sort of the how-to of achieving good quality cervical radiographs. So I like to have these horses lightly sedated. You don't want to overdo it so that they're wobbly, but just a little bit of sedation is super helpful. Make sure to put them in a rope halter so we don't have these metal buckles superimposed on the back of their skull and cranial neck. I use a headrest. At the University of Florida, we really like to use a garbage can. I know that's very fancy, but it actually works really well. I have a picture here I'll show shortly. One of the biggest tips I can give is to put tape where you're going to center your x-ray beam. So you want to try to center on a vertebral body. So I kind of palpate, try to identify where I'm going to center, put tape on, and actually center my x-ray beam on there so that if I feel like I'm a little off and I need to move, I know where I started. So it's easy to go back and modify that a little bit. Have the horse stand as squarely as possible. Again, try to center on vertebral bodies, not the disc spaces. I'll show you what I mean by that shortly. And then again, when you get to the caudal cervical spine, I really close down my collimation to reduce scatter and improve image quality. So your standard radiographic series of the neck really includes lateral projections. It's probably the only area in the whole horse where we don't have standard orthogonal views. So we're already at a little bit of a disadvantage when it comes to cervical radiography. And on top of that, it's a really challenging area to evaluate because of all the boning protuberances and et cetera. So we want our standard series to include everything from the occiput, so the very caudal aspect of the skull, including the nuchal crest in the basioccipital bone. We want to get all the way back to at least T1 or C7, T1 if you can. And so somewhere between 4 and 7 lateral views is about what it takes. And then from there, oblique views are, for me, something I add on as needed. Anytime I add on oblique views, I'm going to add on both sides. So it adds a lot of time and a lot of work, but I really do feel like it can be super valuable, which we're going to get into shortly. So just a quick word on quality control here. So when you're taking lateral radiographs of the neck, what you want to look for to determine if they're good quality is superimposition of these transverse processes. So C6 is kind of an easy example because they're so big. So we can tell there's two, but very, very little of the other side sticks out. It's quite superimposed. So that's a nice, good, normal lateral projection. This one is too oblique. So I can see one transverse process up here and the other down here. So they're separated. Oopsie. Oops. A little bit too much. So that is your x-ray beam is either pointing down or pointing up rather than being horizontally positioned at the neck. And in this case, it's oblique in a craniocaudal orientation. So I can see the cranial aspect of one transverse process in the front. And then the second one is superimposed just caudal to that. Same thing here. Here's one transverse process. Here's the other. And that tells me that the horse's neck is either bent just a little bit away or a little bit toward the generator. So when I see that, I'm going to straighten out his neck and try again. Moving on to oblique projections. So again, these are kind of a tailored part of my exam. So I start with laterals and I'll add on obliques when I feel like it's indicated. based on whatever I'm seeing on my lateral projections. So the most common location, especially in the population of horses I'm generally looking at, is the caudal cervical spine for pathology. So that's usually the location I'm going to be taking oblique projections. These are challenging to take, and I definitely welcome any questions or pointers or discussion about this at the end. But what we find works best is to position the horse again, just like you do for your lateral radiographs. We like a garbage can. They can rest their chin, and that gives you a nice level neck, slightly sedated. And then you're going to position your generator and your plate so that your plate is up against the horse's neck. If you pull it back too much, you'll get magnification. And you want your X-ray generator sort of parallel with your detector. And you can shoot it either way, dorsolateral to ventrolateral, or like here, ventrolateral to dorsolateral. And I prefer this way. It just tends to work out better in our room. And this is shown with an overhead standing system, but it can certainly be done with a portable unit. Then you want to label the highlighted regions on your radiograph, which is also sort of something to wrap your head around. I know that is a challenge to me every time. So just to kind of give you a 3D perspective on that, this is a cross-sectional look at this horse's spine, so as if his head is coming towards us. So we have the detector on the horse's right side, just like we have pictured here. And our X-ray beam is coming from left ventral to right dorsal through the detector, and we're shooting right through the right-sided articular process joint. Now, whenever we shoot at one angle, we have to remember with radiography, we're always highlighting the opposite plane, which means if I'm shooting left ventral to right dorsal, I'm highlighting left dorsal to right ventral. And so my projected image looks like this. I am going to put the left marker at the top and the right marker at the bottom. And that makes my right articular process joint, the side right next to the plate, projected ventrally right on top of the spine. So here's the joint. You can see the arrows pointing at the two joint surfaces. This is the right articular process joint. This is the left articular process joint. And this is the left intervertebral foramen, which is another important site to look at. And so the angle of obliquity is going to depend on where you are in the spine. I can tell you that when you're taking these, it really does feel like you're very vertical. So you really feel like you're pointing straight up at the sky. And for the mid-cervical spine, you sort of are. So those articulations kind of sit at more of an acute angle. So you want a steeper angle with your X-ray beam, somewhere around 50 to 55 degrees. And in the caudal cervical spine, just slightly flatter. It's just because the angle of those facets is a little bit different. So we can shoot at somewhere between 45 and 55 degrees. And this is just a 3D model to show you how the image is projected. So here's one articular process joint, and then here's the opposite side. So why do we take oblique projections? So these can be really helpful for helping to lateralize pathology. I'm going to show some examples of that. And to just kind of give us one more view, one more evaluation of the articular process joints. Just a little bit on quality control here. So this is our well-positioned oblique projection. This is what we're aiming for. And we can see one articular process joint up, intervertebral foramen. The right articular process joint is down, which means the right side was against the plate. We can see the articular surfaces and the joint space. What I want to see is that joint superimposed on this C-shaped intervertebral disc space, and I want it right down the middle. And that's really important. So you can see if our angle is not steep enough, like in these two, which is usually the more common problem, the joint here is superimposed at the top of this disc space. So here's our disc space, here's our joint, and it doesn't give us that nice face-on evaluation. Now this one's oblique in more than one plane, so it's kind of hard to tell what's what, but I can tell that there's one articular process joint is in here somewhere, and the other one's up here. So again, they're too close together, too close to looking like a lateral, not deviant enough. I need more of a steeper angle. So bottom line, get this joint space over this disc space and right in the middle. And it takes practice. This is just an example showing how we can really localize pathology. This is a middle-aged warm blood horse that had a septic articular process joint. And on the lateral radiograph, it's really hard to tell which side is affected. We can see there's all this proliferation and irregularity, and it goes all the way up the C6, sort of dorsal aspect of C6. But it's hard to tell which side is affected. And so this is a great time to use your oblique projections. And so in this case, I have the right side projected dorsal, the left side projected ventral. We can see all this proliferation with the left articular process joint. And so that tells me it's left-sided. And then always do the opposite oblique. And so here's my left side projected dorsal, and we can see even a better view and more of the extent of that proliferation. And then here's my right side. This is not a perfect oblique. I would prefer for this to be a little steeper and projected down ventrally here, but we can tell that it's left-sided pathology. Okay, so that's that on sort of the how-to, and I'm happy to talk more about that later. Moving on to common abnormalities. So unfortunately, we don't have that much time, but I am going to cover trauma, degenerative joint disease, and then wobblers, which, as we all know, changes names every 5 minutes. So I'm going to refer to it as CVSM throughout this talk, but call it what you will. Okay, so starting with trauma, so this includes things like fractures, subluxations, or luxations of the cervical spine. So some of the most common configurations are going to be physeal fractures in young horses. Remember, they have those cranial and caudal physes in each vertebra. They can get laminar or articular process joint fractures, often stress fractures, so those can be quite subtle. And then transverse process fractures can occur. And so I've got some examples here. This is a luxation at C12, so the dens is sitting ventral to C1. It's supposed to be up in here. This guy has a full sort of pedicle fracture, and we also have subluxation, so you can see dorsal elevation of C3 relative to C2 with narrowing of the disc space and widening of the vertebral canal. And then this is more of a comminuted sort of physeal fracture. So whenever you see these, you want to try to determine whether or not the vertebral canal is involved. So it's really important to figure out if there's spinal cord injury or potential for it. And the best way to do that is to take lots of views. So we want to get our laterals as always, and then add on oblique views. This is a great time to use your obliques. And this is a good opportunity for me to shout out for standing CT if you have that available. Obviously we don't want to lay these horses down if we can prevent that, but CT can give us a lot more information when it comes to subtle fracture configurations. And just remember that even if you feel like, okay, the vertebral canal is spared on day one, that may change down the road as these fractures begin to heal, and in callus forms, you can get compression of the spinal cord or nerve root. So sequential radiography is super helpful in these cases. Okay, degenerative joint disease. In my practice, this is far and away the most common pathology that I'm seeing. So this is basically osteoarthritis of those joints, just like arthritis of any other joints. But this affects the articular process joints of the neck. The most frequently affected area in horses is C5 to C7, so it tends to occur caudally. And we can see things like modeling of those joints, enlargement of the articular facets. I always think it looks like somebody took their thumb and sort of like mushed it right there on the articular surface here. So they'll look big and sort of ill-defined, and we'll get proliferation. If it gets bad enough, these things can ankylose, just like other joints, and they can certainly get fragmentation due to things like OCD, trauma, or synovial osteochondromatosis in the joint, so they can get little fragments in the joint. So just some different examples here. The left two are mild, so we can see a little bit of loss of that clarity of the joint space, a little bit of enlargement, but nothing terrible. It does extend over the region of the intervertebral foramen. Same down here, a little bit of irregularity at the joint surface. And then we get into moderate. This is more significant enlargement, more irregularity going down the articular region. And same here, a little bit more enlargement going up dorsally as well. And then these two cases are more severe examples. So there's pretty severe enlargement. We can see the proliferation extends all the way down to be at least superimposed on the level of the vertebral bodies. And it's quite irregular and proliferative. Now, what we don't know from a lateral projection is which way that proliferation is going. Is it going in towards the spinal cord and down towards the nerve roots, or is it going out away from that delicate tissue? We can't tell. And so to some degree, we use our clinical findings to try to determine that. So with osteoarthritis alone, so just joint pain without impingement of the nerves or the cord, your clinical signs will include things like neck pain, stiffness, limited range of motion of their neck, abnormal head and neck carriage, depending on where along the spine it's affected. If that impingement is causing radiculopathy, meaning the articular process joints are big enough that they're compressing those nerve roots as they come out the foramen, or they're causing at least irritation of those nerve roots as the horse goes through its normal range of motion. Then our clinical signs, again, could include neck pain, but in these cases, we might see things like regional sweating, muscle atrophy, maybe more related to poor performance, stumbling, and sort of obscure or atypical, hard to block forelimb lameness. And then finally, those changes can be severe enough that they can cause change in shape or narrowing or compression, narrowing of the vertebral canal or compression of the spinal cord. And in those cases, this is when it becomes sort of wobblers. And so these horses present with clinical signs like ataxia, paresis, and spasticity, with their hind limbs being more affected than forelimbs. So it is helpful when our clinical picture sort of fits with our imaging picture, but we all know that we don't always get so lucky. And so we also know that these degenerative changes in the neck can be present absolutely without any clinical evidence of disease. So we may see them on things like a pre-purchase examination. There's a recent paper by Hausler and others that showed in their population, a pretty large population of horses, there were osteophytes and enthesophytes along the neck from C2 to T3 in 72% of horses. And these were not horses that were necessarily clinical. They were just kind of a random population of horses. So pretty high prevalence there. We do know that older and taller horses are more likely to have osseous abnormalities at their articular process joints. It doesn't necessarily mean that they're going to be clinical for it, and that it's normal for the C5-6 articular process joint size to increase as horses age. And finally, that enlarged articular process joints can be absolutely clinically incidental in the caudal cervical spine, which is where we see the most, C5 to 7. And so what do we do with that, right? So it's, if we have clinical signs and we have imaging abnormalities, one of our questions that we have to answer is, so is this a cause and effect? Like, are these radiographic abnormalities the cause of the clinical signs? And so the best way that I can think of to approach this is, number one, if you have certainly neurologic signs, is to rule out other causes of disease. So we want to make sure that we rule out infectious causes like EPM, herpes, encephalitis, and West Nile, and certainly take radiographs to rule out trauma. We can use ultrasound. It's a really nice complementary modality for these. So we can look at the periarticular margins of the synovial facets. It always looks like a little like dolphin mouth coming out of the water to me, but there's one, there's the other. We can actually see the synovial membrane nicely. And we can use our ultrasound to look down into the joint and see any indication of synovial proliferation or debris. And so that may sort of add credence if there's concurrent synovitis to our finding that maybe, hey, the joint capsule is distended enough to be causing, a problem, or this could be a source of pain. Diagnostic analgesia, I know there probably are people out there that are blocking these joints. It's not something that I am very familiar with, but I'd love to hear from you if you are, to hear your experiences. I think it's possible. And then certainly response to therapy. So if we have a strong enough suspicion that these are in fact the source of pain, we can try injecting these joints and seeing how they do, and sort of using that as a diagnostic as well. There are some radiographic findings that I feel like have a little bit more weight than others. So just general enlargement of these articular process joints, maybe in an older horse, means less to me than some other findings, and I'm going to cover some of those. So asymmetry. So if the articular process joints are asymmetrically enlarged, that tells me that one side is likely abnormal due to arthrosis. And so this is an example of a lateral projection in a horse that has enlarged articular process joints, but they're asymmetric. Here's one, and the black arrows point to the other. So that may have a little bit more clinical relevance in my mind. I also just wanted to point out some of the nice lytic changes we have in this articular process joint. So the white arrows are pointing to. So asymmetry has a little bit more weight for me towards clinical relevance. And then I look for superimposition of proliferation on the intervertebral foramens. We talked about how the nerve roots come out of these sort of lucent foramina. And when we see proliferation, like this horse has a pretty marked amount of proliferation at C2-3. I don't know from this view if it's proliferating out and away from that nerve or if it's going in. But when I take my oblique view and I can see, okay, now it's superimposed on the foramen on my lateral and it's still superimposed on my foramen on my oblique, I start to have a little bit more concern, like, hey, maybe it's actually protruding into that foramen. So I do put a little bit more weight on that finding. And then finally, fragmentation. And so there's a nice paper that talks about the significance of articular process joint fragmentation. And they found in symptomatic horses, up to 24% of them had fragments. So there may be some clinical relevance there. And this is just an example. This is a lateral projection, and it just looks like, there's a fair amount of proliferation dorsally. And then when we get into our oblique projection, we can see that the left articular process joint has a fair amount of proliferation, and then it has this, these fragments associated with it. And so I really look carefully to try to, this is a big one, but I try to identify subtle fragmentation and tie that in with my clinical findings. Okay, moving on to Wobbler's disease. So cervical vertebral stenotic myelopathy, or CVSM, by definition, this is stenosis of the vertebral canal, anywhere from C1 to T1, that results in spinal cord compression. And so with this, we can get upper motor neuron paresis, ataxia, spasticity, and weakness. Oftentimes, I think I said previously, but oftentimes the hind limbs are more affected than the forelimbs. And it's often symmetrical. And these horses will have normal mentation, normal cranial nerves, and normal reflexes. So there's sort of two major types of CVSM. So type 1 is our kind of younger. These horses are probably born with this problem. Light breed, often thoroughbred type horses. They tend to be affected in their cranial to mid cervical spine, so C3 to C5. Oftentimes it's a dynamic lesion, meaning it doesn't necessarily compress at all times, but it compresses as the horse goes through its range of motion. Oftentimes inflection in the cranial cervical spine. And then, but those horses, may not show themselves until they start going to work around 2 years old or so, even though they've been affected, probably their whole lives. The second type is mature horses, but they can show up as young as 1 year of age. And that's why there's sort of a Venn diagram here, because they can be sometimes challenging to differentiate. These horses have asymmetric articular process joint enlargement or osteoarthrosis, oftentimes due to degenerative change. This tends to be the horses that are affected in the caudal cervical spine, so C5 to C7. And this is often more of a static change, but again, there's some overlap here, so they don't always read the book perfectly. So radiographic findings, I'm going to talk a little bit about the measurements we make to get subjective sort of evidence for this disease. But first, I start with my, so first I start trying to gather subjective evidence, and then I do measurements for my objective criteria. And so things that I look for that we know to look for radiographically. So epiphyseal flaring, so the caudal aspect right over the epiphysis, has this little bit of a sort of a ski slope or a flared appearance. We can see elongation of the dorsal lamina. So here the lamina extends, and now it extends beyond the length of the vertebral body and over the one caudal to it. So it should stop where the vertebral body stops. And so that's elongation of the dorsal lamina. Osseous proliferation, this horse has a really good example of a large amount of extensive articular process proliferation. And then subluxation or abnormal alignment of the spine. And so this horse going from C5, you should have sort of a 180-degree straight line down the vertebral canal. And as we get here, we start to see narrowing of the vertebral canal, dorsal angulation of C6 relative to C5, and it results in sort of this cone shape to the cranial aspect of the vertebral canal at C6. And so none of those are definitive evidence that says, yes, we have wobblers. Yep, spinal cord is compressed. We can't do that. But we can use it to say, okay, I have a neurologic horse, and now I have findings that support that he could have wobblers. And so it raises our index of suspicion a fair amount. But the goal with these horses is to predict if they have stenosis of the vertebral canal, and thus if spinal cord compression is present. And so over the years, there's been lots of different sort of radiographic measurement techniques that have been done to try to identify sort of a more objective, definitive way of saying, yes, we're concerned about spinal cord compression. And I think there's sort of one clear winner. So nowadays, pretty much the best approach here is to use intra and intervertebral sagittal diameter ratios on, and they have to be made on well-positioned lateral views of the spine. So making sure that it's A, normal anatomy, and B, positioned appropriately. But, and so I'm going to walk you through those measurements, but just bear in mind that there's still a little room for error. And so in the end, myelography is really going to be our gold standard as far as antemortem testing for this disease. Okay, so there's a really nice paper by Hahn and others. It's a few years old now, but this describes these measurements really nicely. So if this is something you're doing a fair amount or you want to be doing more of in your practice, I highly recommend reading this paper. But basically, you measure sort of two different ratios. So the intravertebral sagittal diameter ratio is the ratio of A over D, meaning within any vertebra, you're going to measure the narrowest point of the vertebral canal, which would be A. Oftentimes it's cranial, but not always, and put it over the height of that same vertebral body at the level of the cranial physis. And I'm really careful about making sure that this line is perpendicular to the floor of the vertebral canal. So that's your intravertebral sagittal diameter ratio. Then you're going to measure both B and C, and you're going to take the smaller of the two. So from the back of the dorsal lamina to the cranial aspect of the body of the more caudal vertebra, and from the front or cranial aspect of the dorsal lamina of the caudal vertebra to the caudal aspect of the body of the more cranial. So these two lines almost always be smaller, but you take the smaller of the two and you create a ratio with the more caudally located vertebra. So in this case, E. So height of the cranial physis of the more caudal vertebra. And none of those ratios should be like 48.5 is your cutoff. So if it's less than 48.5 at any site, then that's a good indication that you have spinal cord compression. So the intravertebral ratio is not site specific. It just tells you it exists somewhere. Interestingly, it may not exist at the site where the measurement was lowest. That's odd. The intervertebral sagittal diameter ratio is a little bit more site specific, but those are the measurements. I am super duper careful in sort of anal retentive when I make these, because oftentimes I feel like there's big decisions on the line. So I will just kind of show you how that applies to radiographs. So I measure the height of the vertebral body. I try to make the line perpendicular to the floor of the vertebral canal. And then for my intravertebral sagittal diameter, I'm going to choose the narrowest point along the vertebral canal and measure that perpendicular height and create that ratio. So blue over gray would be my intra. And then my two options for intervertebral sagittal diameter would be purple and green. And again, I'm going to put them over the gray line if I'm measuring between these two vertebrae. And so this, I would do green because it's shorter over gray as my inter, and look for that a number smaller than 48.5%. I actually measure each of these 3 times, and I take the average because, again, I feel like it's a big decision oftentimes is hanging on the line. So this, for those of you that have residents out there, this is great opportunity to torture your residents. They really love it when I make them do a bunch of math. But that is how that's how I like to do the measurements. And in the end, they can have a relatively good sensitivity and specificity, but we really still, use that to say, okay, now we're really concerned. We have subjective criteria, we have objective criteria, we have clinical evidence, and the final step to sort of prove that we have compression would be a radiographic, or nowadays CT myelogram. And so since we're talking about cervical radiography, I would be remiss to not include sort of the how to do myelography. So this requires general anesthesia. We place the horses in lateral recumbency, and we prep our subarachnoid space at the cisterna magna. We use an 18 gauge needle. We once our needle is in place at the AO space, we collect about 50 mils of CSF and slowly inject the same volume of contrast. Then we elevate their head for 5 to 10 minutes, and then we obtain our radiographs. So we get lateral radiographs in neutral, flexed, and extended positions, because I really want to put that neck through its range of motion and see if I can identify an area of dynamic compression that may not exist in just one position. So how do we determine if there's compression? So there's sort of 2 major criteria. The first is the dorsal diameter reduction rule, or 50% reduction. So we look primarily at the dorsal subarachnoid space. So here's our dorsal contrast column. Here's our ventral contrast column. This ventral one does not mean that much. When we get compression of the dorsal subarachnoid space is when we have indication of compression. So if the narrowest point compared to the more normal intravertebral subarachnoid space is 50% less, then that's an indication that there's compression of the spinal cord. And the second one is reduction of the dural diameter by 20%. So if this line is 20% or more reduced relative to this line, then that tells you there's compression. Okay, and so this is a middle-aged warm blood horse that presented for hind limb ataxia. We had evidence of compression on myelography. This horse was actually interesting in that we could see contrast media within the spinal cord itself here. So not just in the dorsal column and the ventral column, but in the spinal cord. We had marked reduction of the dorsal diameter compared to here. And this horse sadly had to go to necropsy, and this is what the spinal cord looked like. So completely crushed with myelopathy in the spinal cord. CT myelography, this is definitely a new up and coming toy for us, and I'm really excited about this potential because I think it's going to really revolutionize the way we manage these horses. But CT of the cervical spine gives us a 3D evaluation. It removes any of that superimposition and lets us look sort of slice by slice through these necks. In addition to that, we get a fair amount of soft tissue evaluation. With the addition of myelography, we can't necessarily tell in plain CT, but once we add contrast to the subarachnoid space, we can really identify areas of spinal cord compression. And probably the biggest benefit of this over radiographs is that we can identify lateral compression. So when we talk about radiographs, we're talking about compression of that dorsal contrast column or that dorsal subarachnoid space, but we really can't tell if they're squished sort of from side to side on radiographs. So we're missing a whole sort of component of the picture. that we can see in CT. We are able, not all scanners are able to do this, but in our scanner, we're able to get dynamic views, so flexed, extended, and neutral positioning of the neck, although we're still doing radiographic dynamic views as well, just to kind of gain more information, but we can take them through their range of motion. And so pretty exciting, sort of very recent development. And this is an example of a horse that had, degenerative changes of his facet. So we can see that the right articular process joint is larger than the left. There's a fair amount of subchondral bone sclerosis in this right-sided articular process joint. There's periarticular modeling or enlargement there and there. We can actually see some of that on the other side, a little periarticular proliferation. I didn't include the soft tissue window, I don't think, but you could see synovial proliferation from this joint as well, if I showed it to you in a soft tissue window. And if we look carefully at these intervertebral foramina, you can see this side is quite narrow compared to the other side. Now we want to be really careful that we're reformatting these appropriately so that we don't artifactually create this appearance, but the side is narrow, and so there's very likely compression of that nerve root as it tries to exit the foramen. And then finally, if you look at the subarachnoid space around the spinal cord in this case, it's quite narrow laterally. And if you were looking at a lateral myelogram, it would be really difficult to appreciate that because the dorsal column, which is here, isn't necessarily going to be narrowed because the compression is lateralized. So CT is really kind of a game changer in that perspective. And so this is just kind of showing you an example of how we can play with them. These are just markers as to my positioning, so I can use these to sort of align myself down each side of the spinal cord as needed. I want to look at them, my transverse view, my dorsal plane, and then my sagittal plane, and sort of tailor it to each site. And this horse is another example of a fair amount of articular process joint degenerative change. He's got irregular margination of his articular process joint proliferation, and he had this little osseous fragment down here in the vertebral canal. And that is the end, and I'm happy to take any questions at this point.
Okay, thank you, Erin. We've had a few questions come in already. As a reminder, please enter your questions into the chat box and we'll get through as many as time allows. I think we've got about 5 more minutes here, but all right, Erin, let's get started. First question, can you do flexed and extended views during the standing CT or only under GA, general anesthesia?
Yeah, so those are under general anesthesia, and I should clarify that. So with the standing CT, we're not doing myelography, so I'm not comfortable. I know there was a paper a while back, I think out of Canada, where they did myelography through the LS space and standing horses, but it's not something that I'm real comfortable with or excited about. So we're not doing standing myelography. We're just doing standing cervical spines. And in our scanner, we can only get to about C4 or so. And so in order to get the rest of the cervical spine, then they need to be recumbent. And in those cases, yeah, we can put the neck through their range of motion, but not standing. I don't think the horses would tolerate it very well either, unfortunately. It'd be cool though.
Okay, next question. How do you move the neck of the horse to extend flex in CT? Just manpower? They said we have a CT with a diameter of 90 centimeter in our clinic. How do you scan the flexed neck?
So the scanner that I'm using is specifically modified for recumbent horses. So they're down on the ground level. I think I have a picture here I can go back to. Yeah. So this horse is actually laying on ground level with his head in the scanner. And what you can't see is sort of back here, we have ropes leading from his head, tying back here to put him in extension. Inflection, we have a cervical and we actually flex their necks and tie it down in the cervical. So they're in what you can see here, they're in flexion like this. And then neutral is just a neutral position. And we scan through the caudal and then again through the cranial aspect of the spine in each of those positions.
Okay, thank you. Do you have any tips and images for ultrasound injection of APJs?
I have well, I don't have an image of an injection. I just had the one ultrasound image here. Let's see. So as far as tips go, I mean, the most helpful thing for me is just to practice, try to do it on your, on your own horse or on a horse when you have a little bit of time. But what you're looking for is and I would suggest using a linear probe, like a tendon probe, rather than a microconvex for just looking at the joint. If you may be more comfortable injecting with a curved probe, that's okay. But you're looking for sort of this whale mouth shape kind of pointing straight up. So this is one facet, this is the joint space, and this is the other facet. And this view is a little bit more challenging. You're trying to angle your probe sort of in long axis right down into the joint and get a view of the sort of intracapsular view. But I think the best advice I can give is just lots of practice, kind of trying to identify where they are. And then, yep, this image is made with your probe in sort of a long axis, so marker is proximally. I'm not sure what other advice I can say there, but I'll keep thinking about that.
Okay, next question. How clinical significant would you consider the ski jump appearance at the caudal physis?
Yeah, so not extremely. So if you read, and the question is with regards to this, I believe. So there is this sort of, and most of the literature is very consistent with these subjective parameters. So looking for the ski jump appearance to the caudal physis, looking for elongation of the dorsal lamina. And like I said, to me, these are not things that you would hang your hat on, but I do find that if I have a horse that, fits the bill clinically, the more sort of findings I have that go along with it, the more credence I have for that, for sort of believing in it. So it's just one more finding that goes, okay, well, that fits, and we have articular process enlargement, and I have, and then I'm going to do my ratios. And if my ratios fit, then all those things together really help paint the picture for me. But I certainly would not, hang my hat on that finding alone in any way, shape, or form. And if it were the only finding and there was nothing else abnormal, it wouldn't bother me. I probably wouldn't even think much of it at all.
Okay. I think we've got time for one more question. What about if contrast does not go all the way down the spine?
And
So
am I
we
like,
have problems sometimes, even if we try to move the neck.
so I guess my question would be is what strength of contrast are you using and what dose? And I know it's probably hard to answer, but I can tell you my suggestions. So we draw off usually about 50 mils of CSF and inject at least that volume back in. The strength of contrast does matter. And a couple of years ago, there was a contrast media shortage, and I know people ended up with different strengths. So I would suggest 300 or 350 mgs of iodine per mil. So double check the strength. And if you're doing all that, maybe hold up the neck a little longer. We do hold the neck, like the head, elevated for 5 minutes or even up to 10. And if we are not seeing good flow of contrast, you can hold it up a little bit longer, and that can be helpful. And then finally, just really making sure you're getting good quality images of the caudal C-spine. So what I have found probably the most commonly is that it's getting back there, but it's hard to see because we have thick soft tissues back there. So really collimating in that caudal cervical spine, and sometimes modifying your KVP. So you want your KVP for these to be a little bit on the lower range, and that can really help amplify the contrast media. So those are kind of my pointers on that.
Okay. All right. Well, thank you again, Erin, for sharing your insight and expertise with us today. And thank you to everyone who joined us for the webinar. If you enjoyed today's presentation and would like more information about the further 2 webinars in our Equine Winter Webinar series, You can scan the QR codes. We're going to bring that up on the screen here. And we will also share this information with you in the follow-up email. If you have any additional questions, or if you typed a question in the chat box today that we unfortunately didn't have enough time to get to, just get in touch with us using the contact information shown here or by taking a look at our website. But QR code should be up on your screen now. So thanks again to everybody and enjoy the rest of your day.
Thank you.